So today our speaker is Dr. Charlie Resnikoff, the Charlie Resnikoff, and he's going to be talking about hot topics in the fight against fentanyl and meth. So we're excited about this talk. It's part 2, and he did his last one what, 2 weeks ago, 3 weeks ago?
Yeah, just remember Charlie's fun, and he said it's going to be a little interactive. He hopes that people are going to be fired up to do this. So, all right, other announcements. Upcoming, Alex is coming back. As many of you may have remember, he's really a fun talks, really a fun speaker. So that's next week. We got a lot of other things coming up. I'm kind of looking forward to Dave Rossmiller. He's doing that whole thing on opium, which I'm dying to hear about.
There is free CME offered with these sessions. Just make sure you fill out the stuff that Katie sends you following these sessions to get your credits. And we love to see your faces, even if you're eating your lunch. So turn your cameras on.
All right, and remember, if you have some questions, please give us a call. We always get fun calls. Had one the other day. It was kind of interesting. So if you need to, please just reach out, talk with Aaron, or you need to get hold of me. Either way, that's just fine.
And Stratus Health is the home to the core website, and it's just a bunch of gathered policy, protocol, and information. So check it out if you have any needs in that regard.
And then Charlie's talk. So we will see if he popped on yet.
He's here.
Oh, there he is. Okay. Hey, Charlie. So we already introduced you, told people this is going to be a little interactive and kind of a fun echo, if you will. So
yeah,
the floor is yours.
Oh, okay. Sorry, I'm of course signing one more order. Signed. Okay, so and then I'm gonna just get all my windows down so I don't get pinged or harassed. Okay. And Katie, did you have a PowerPoint slide deck for me?
Yep, I can share them if you want.
That'd be awesome.
Okay.
First of all, for anyone who doesn't know, it's like the pillars that hold the world up in Greek mythology. That's Katie, and I have been just going from one deadline to the next, and I was late, and Katie helped me, and huge props to Katie. You cannot appreciate enough the behind the scene work that she does to make this to make it fun and easy to do this echo.
It's actually traumatizing to know how organized she is sometimes, Charlie.
Yes. Got it. Okay, so let me just tell everyone no calls till 1:15, and then I will start the party. Okay. All right. Yes. Katie is a rock star. Moral of the story. There's no discussion about that, but there will be discussion about a bunch of other topics today. So there'll be audience response, and there'll also be throw some comments in the chat. And I am going to give you my opinion, but it is only just that. It is my opinion. Some of these topics are kind of hot topics. So Katie, next slide. Okay, so here are the hot topics. Treatment of stimulant use disorder, opioid death rates in Minnesota, legalizing drugs, methadone regulations, and optimizing buprenorphine. Next slide. Okay, first hot topic. Do you believe that you have effective treatments for people with stimulant use disorder? And if you're not a clinician yourself, maybe your partners or your clinic have effective treatments. Do you believe you have effective treatments? Boy, and I don't even know what my answer is on this. I think I'm going to give you this answer. And then whatever y'all think the optimal time is to wait, I'll let you reveal what you think would be good.
That's a tough question.
Yeah, I mean, I said no. I'm going to talk to you about what we have, and then we can decide whether those are effective or not. Kurt, what'd you say? Or Aaron, what'd you say?
Yeah, I would say it's effective. It's at times effective for some people.
Yeah.
And some of the things I use, there are people that are responders, and I would say the majority are non-responders.
Yeah, got it. Yeah, I feel it. Next slide. I feel similarly. So, okay, what has worked for you? I want to just hear some things in the chat, and I'll start. Well, I'll wait. But throw some things in the chat that you think work for you or you have seen work for patients. And it doesn't just need to be pharmacotherapy. It could be any intervention.
Exercise, like that.
Immunizations. Oh, you mean like drug vaccines?
Yeah, sorry, I didn't know the politically
Ooh,
correct way to say that.
Topamax. I don't include any information on Topamax. I need to add that. That's good. Okay, you guys can keep throwing those in the chats. Peer recovery support specialist. Awesome. Wellbutrin and naltrexone, Kurt. Okay, so yeah, okay, this is awesome. Only treat polysubstance. We use Suboxone for OUD. Okay, this is awesome. So I'll just show you what I have, and I don't actually talk about Topamax, but I have a reference where you can find the Topamax information on it. This is the kind of the classic study that was partly done at Hennepin, looking at naltrexone and bupropion, Wellbutrin. Got it. And there's great ongoing chat stuff is great if you keep an eye on that. The thing about this study is they had 95% treatment adherence in the study because they were giving people little financial incentives to show up and take their medications. So there was that. And the other thing about the study is these were very, very severe methamphetamine users. And the third thing about this study is basically nobody can get every 3-week intramuscular naltrexone for methamphetamine use. So there are some generalizability issues with this study, specifically with the naltrexone, but just in general. Nonetheless, a subset of people who were treated had significantly less methamphetamine use. Next slide. I think based on this meta-analysis that in the prior study was basically the benefit probably mostly came from the Wellbutrin, the bupropion, because if you don't have naltrexone, if they have opioid use disorder, they should first be started on methadone or buprenorphine because methadone or buprenorphine has mortality benefit. So if you have both opioid and stimulant use disorder, like a comment said, we should be starting with buprenorphine or methadone first. And then if you add bupropion on top of it for the stimulants, it does help reduce some outcomes or improve some outcomes. So, but you're not going to give naltrexone in that circumstance unless they specifically do not want methadone or buprenorphine. So in other words, I actually think the bupropion, the Wellbutrin, is probably the mover and shaker with the naltrexone bupropion combo. I still always give naltrexone because of adulterated methamphetamines that have fentanyl in it. At least it would be protecting them from fentanyl exposure, and maybe there's a benefit. I know this isn't about cocaine, but I do have a patient who's telling me he's responding to naltrexone for cocaine. So you do occasionally hear that naltrexone alone works for stimulants, but I think bupropion is the mover and shaker. Next slide.
You know, Charlie, can you comment on the dose of that? Because 450 is a boatload of Wellbutrin.
Yeah. And I think the study had people starting at 300 and then titrating up to 450 as tolerated. And I have no one on 450. And remember, these are really, really heavy methamphetamine users in the study. So in my practice, I'll start them on a lower dose and build it up slowly. And usually by 300, they're either responding or not. And I've rarely pushed someone to 450. And I have had patients tell me that bupropion has helped them use less meth, even not at 450. So I don't think that the 450 of bupropion is super realistic. I don't think that every 3 weeks naltrexone is super realistic. But I think there's enough there to have me try those medications in more clinically applicable doses, if that answers your question. I don't know what other people do.
So is that the same thing as Contrave? Because Contrave for weight loss is naltrexone and Wellbutrin, correct?
Oh, I don't know that. I believe that.
I'm looking it up on my Google machine right now, and it is. So I'm going to keep looking at dosage stuff because that's really interesting.
Yeah, there's a great comment. Thank you for that. It's like a branded weight loss thing. Thank you for that. Seizures are increased with bupropion, so be careful with that. Potential concerns with bipolar disorder and potential concerns with anorexia nervosa. Those are and then renal. I think there's a renal adjustment as well. So there's kidneys, bipolar, seizures, and anorexia nervosa are the sort of cautions with bupropion. But I do use it. So here's another study that is different in that this had very poor study adherence, like less than 50% of the study participants stayed in the study. And it was almost entirely the men who have sex with men community in San Francisco. So is that generalizable to your population? Maybe, maybe not. It was a simple 30 milligram mirtazapine at night, and it did show a significant reduction in methamphetamine use. It didn't help some of the other things. So I really like mirtazapine. I'm not worried about the men who have sex with men. I don't think there's anything too unique. Maybe I won't let that stop me from using it in other populations. And the fact that it was really poor study adherence, in my mind, it makes it a more realistic trial in my mind. So I like mirtazapine as well. Next slide. I want to get your sense on this. So let's take a poll. What do you think about Adderall? And I'm going to include Adderall, modafinil. I'll include modafinil, Adderall, and Ritalin, Concerta, the whole 9 yards.
Man, you're going to make us make this decision here, Charlie. This is
Well, it's not a binding decision, and I won't be taking your referral information and posting it online so that all the patients will come to you looking for this. Because if you want to have a new clientele, start prescribing stimulants for stimulant use disorder.
Well, this was a big topic at ASAM.
Right, for sure. And that's kind of what's exciting me to talk about it. So everybody can see the results. Is that right?
Yep.
Cool.
But they should be able to if people can't, but.
Yeah. Okay. So most people would say only if ADHD is present. There's 15%. Yeah, I'd do that. And 15% nevers. My personal practice since, I like you need more info, Bach. Christine Bell says, need more info. My personal practice, since I don't treat ADHD myself, I'm a never. And I've done it once and I frankly regretted it. I don't treat ADHD. I have patients with ADHD who go and get this treatment, and I don't object to them and I don't try to intervene or stop it. If they have a proper ADHD diagnosis and they're on Adderall, I'm not against it. So I'm kind of in the middle box, but I wouldn't prescribe it myself because ADHD treatment is not part of my practice. I personally would not give stimulants for stimulant use disorder. That said, the ASAM guidelines, and there's a link below, or if you want, I can throw it in the chat. The ASAM guideline says, there's a potential role for this, and that's interesting. But that comes with some caveats, and I'm just about to throw this in the chat. This guideline is pretty intense. That link probably doesn't do you much good. This guideline is pretty intense. Look, if you could just Google ASAM 2024 treatment guidelines. This guideline, stimulant use disorder guideline, ASAM 2024, it's pretty intense. It's very well researched. It will walk you through every study, including the topiramate studies. And it gives you kind of a bottom line conclusion, but it's hundreds of pages long. And so but it's like index 12, so you can go to the relevant page pretty quickly. So if you want to learn more about stimulant use disorder treatment and specifically using psychostimulants, what data is there, what concerns are there, it's all in that guideline, as well as the mirtazapine and the other things. So what they're saying is ADHD treatment may tip you over towards doing this. You got to monitor them carefully. Robust dosing is needed. That's like a trigger warning for me. That makes me nervous. You got to be concerned about the cardiovascular effects of giving someone stimulants. And they say, hey, when in doubt, get an addiction medicine colleague on board if you're not an addiction colleague, addiction medicine trained. Next slide. So I'm skipping over topiramate, but do look at that. I think that's a good one. I think for cocaine and meth. So contingency management therapy. I'm going to ask your opinion about this. Someone with methamphetamine use disorder is given $100 to $200 a week if their drug screen is free of methamphetamines, right? There's relatively short-term studies. It's low overall benefit, but this is as good as any of the pharmacotherapy we have. This is as good as those medications we were talking about. So it is evidence-based, comparable to those other things we were talking about. Most insurers don't cover it, but we're doing it at Hennepin starting this summer. I'm nervous about that, but there will be we got a grant funding and we're doing a trial at Hennepin soon. Next slide. So I want to hear what you think about this. Is this a good idea to pay people $100 to $200 a week if they have drug screens free of methamphetamines? It does improve abstinence rate. But if we step back, is this a good thing? There's a lot of voices promoting this. Yeah, I don't know. We also got this is not sustainable. Oh wait, yeah, here we go. All right, I love this. How do we monitor the drug screen? Is it observed? Yeah, so there's practical questions about whether it's an observed drug screen or not. We could even do oral swabs or other more reliable forms.
Don't you think, Charlie, that if people, wouldn't the study, I'm wondering what they're going to do with this study, because if, let's say some people at a month are doing great, those people you should continue because it works. Some people it's clearly not going to work for, and you're going to see that over a period of time.
Right.
Is that the way they're going to run it, you think?
You know what I think we should do? I'm just going to pitch this because I don't know the answer to the question. We should have one of the members of my team that is running this program come and talk to you about the experience in Minnesota.
Yeah.
I think that could be really cool because we're gonna be doing it at Hennepin, and maybe have Gavin or someone give a presentation on what it is and how it's going, and all these questions. Yeah, and there's a question about whether this is cash money or a gift card. I think it is usually a gift card, and there's various ways, but the dollar value does matter. And if they aren't getting actual reward from it, like if it's, if you're giving them tickets to the Minnesota Orchestra, as awesome as that is, you might not get meth. In fact, you might need meth to stay through one of those symphonies. See, this is what happens when I'm off script. Okay, so we got some questions. Accountability, consequence, rewards. Okay, so for Craig, I am concerned with contingency management therapy because I think incentives revert as soon as you remove the incentives. That's classic. If you do this, you get an incentive. And then as soon as I remove the incentive, as soon as you stop giving me parking tickets, I will stop plugging the meter. I'm sorry, that's just how it is. Nobody has convinced me that I am doing the morally right thing by putting a quarter in the meter. I'm just trying not to get a parking ticket. And that's how that's how incentives are, is they change behavior while they're happening. But I'm skeptical that this creates long-term changes in behavior. So that's kind of like related to what Craig said. And then Robin says, oh yeah, Robin has a question about the contingency management program. And again, like I'm not myself doing it, but my colleagues are, and I think that would be an exciting echo. So we can follow up on that offline to get you more information. And I love Penny's thought. We'll get to this in a second. A direct deposit into a savings account. I'll even elaborate on that. I think that there are ways to make contingency management therapy even better. However, there is like a dose response, and I think the patient feeling the excitement and the reward of a monetary gain is part of it. And the more you separate the individual from the excitement of getting $100, the less effective I think it will be. So again, like we're going to put this in your retirement account. That's not going to change behavior. I'm sorry. It's just like, that's just not immediate enough. It has to be really immediate. So anyways, next slide. So I just want to like dwell on a few things here in this, and that is that I think where a lot of the action is with stimulants and methamphetamines is all the things we can do to help them live healthier while we're waiting for better treatments. So there's Philip Kaufman, and he's in the San Francisco, the person researching mirtazapine in San Francisco. He's just giving statins automatically. He's considering stimulants a cardiovascular risk factor like tobacco. He just starts these folks on statins. It's really interesting. Housing is huge. And then the financial thing is huge. And that relates to some of the comments like the one Penny made. A huge difference for me has been with patients. Like my number one counseling approach is some people cannot manage money on their own. And when money is in their hands, they blow it all on meth. But if they hand over their financial control to a loved one, a mother, a spouse, whoever, or a payee if they don't have anyone in their life, then that money goes to their housing and their groceries, and they don't get evicted. They maintain their housing. They can eat properly. And yeah, they still use meth with whatever money they can scrounge up, but their whole life doesn't crumble. And so a not insignificant number of patients will accept this advice and say, yeah, I want to use meth. I just don't want to blow my entire savings every time my deposit lands in my checking account or whatever. And so that financial, have someone take control of your money is just, to me, if they go that route, and it's not everyone does, but some do, it's game changing. Obviously, syringe programs, drug testing strips. Fentanyl test strips are like not super helpful for opioid use disorder. They are super helpful for methamphetamine use disorder because meth users want to know if there's fentanyl and should know if there's fentanyl in their meth. 15% of our meth in our community has fentanyl in it. So our users, give those people fentanyl test strips is super important. Pre-exposure prophylaxis for HIV. I have seen more and more people accepting PrEP when they're meth users. So that, I think the awareness of PrEP is rising. They are eligible. If you haven't done an echo on that, I can recommend people to give a talk on, it's not that hard. It's very daunting for me, but you don't need to send them to an HIV doctor. You can do this as a primary care doctor. There's a couple little tricks that you need to know about, but it's like once a day dosing. It's very doable. And these patients want it. They don't want to get HIV. So not all of them, but many of them are accepting it now. Syphilis is off the chain in the metro area. We are diagnosing syphilis once a week. It's all the time. So everybody just gets an RPR, and if it's positive, your lab will report it. But there's a syphilis nurse at MDH, and so you can find that number. You can message me if you need, and I can get you in touch with the syphilis nurse at MDH, and she knows all. She will tell you what to do. So start testing RPR in everyone. Obviously, hepatitis C, contraceptive counseling, wound care, and psych services. Aaron, lots of syphilis in jails. Lots of jails. So that's syphilis is huge. We should be testing for that. Next slide. So Where we going? I think we're going the wrong direction. The other way.
Sorry.
It's okay. Keep going. One more. There we go. So methamphetamine, that's it. Any other lingering thoughts on methamphetamine? Why don't we go to the next slide? We got some meds. We got to do harm reduction. There's contingency management therapy. Send them all to Hennepin. Just kidding. I'm sure we'll be totally full on the first day. Okay, let's go to the next slide. Okay. Here's the next question. In Minnesota, unintentional overdose deaths are getting better, the same, or getting worse? So this is like traditional drug overdoses, like the number the CDC puts out every year. 100,000 people died of an overdose. Okay, pretty sweet, pretty split, but the leading answer is getting worse, and I have some good news for you that you are wrong. We are getting better, believe it or not. So in the United States, you could argue, I actually just reviewed more data saying that in the United States, we're getting better. And I'm going to, if you don't have access to this, I'm going to put a really cool attachment in the talk, which is the emerging, the drug threat. And there's a lot of great data. But in the United States, actually, we might be getting better, but we're at least plateaued in the United States. Next slide. But in Minnesota, we are getting better. So from 22 to 23, there was a decrease of almost 30% in drug overdose deaths. And then if you just look at the first quarter, there was another decrease from 23 to 24 of almost 10 more percent. So we are getting better in Minnesota. The pale blue bars are not finalized numbers. So 2024, you have to take with a grain of salt. It's just the first quarter. But 2023 was better than 2022 significantly in Minnesota. Next slide.
Charlie,
Yeah.
do you think there's the same number of overdoses, but there's so much Narcan out there that we're having less death?
Could be. That's the question. So I'd like to hear people's thoughts. And Chantel already chimed in agreeing with you. Chantel thinks maybe better access to Narcan. What else? Any other theories? I'm going to give you my theories in a minute. So I want to hear what you think. I mean, can we all just like revel in a slight glimmer of hope? I mean, I used to, the joke used to be addiction clinicians specialize in graphs that only get worse and worse and worse. Our graphs only go up and to the left. We don't have any graphs that go down. Well, in Minnesota, the graph started going down. So we got Narcan, we got access to buprenorphine, we got access to methadone. We got Cody saying, hey, be careful. We're not ready to call it a trend yet. That said, though it is not the trend, this is the first time in my career that the overdose death rates have gone down. So although it could be a statistical anomaly, it is notable. Okay, but it's a good point.
Charlie, I said I'd retire if it went down 2 years in a row about 10 years ago, and
Nice.
it's never happened.
I think 2024 is going to happen, depending on which data you look at. And if not, we'll see about 25. Anyone else want to throw removal of the X waiver? Okay, these are good. Okay, here we go. Caitlin, up in the iron range, meth has been the most prevalent drugs. Xylazine, fentanyl, and other drugs are becoming more prevalent. Oh, yeah. So there are some communities that are sort of not yet or just getting exposed and are maybe a little behind on the fentanyl cycle. Any community that didn't get exposed to fentanyl and is now seeing fentanyl is going to see an increase in overdose deaths. Oh, it did. Yeah. Yeah. Okay. So, yeah. So onset of fentanyl, the 2017, 2018, I also used to attribute that to widespread increase in naloxone distribution. To Cody's comment, that 2017, 18 looked like good years. And I attributed that to naloxone. But Cody's also pointing out fentanyl. So maybe we were actually turning the corner in 17, 18, and then fentanyl bumped us back in the wrong direction. So maybe that's what happened. Okay, next slide. Here are some of my answers. I want some food for thought. Increasing naloxone availability, you got that. Increasing MOUD, you got that. Fentanyl is now smoked more than injected. People are changing how they use fentanyl. People are smoking now. That might be good news. If there's good, I'll show you more about this in a second. If there's good news about fentanyl being so freaking strong, it's that you can get the high you need from smoking it. And we know that if you smoke something, you're better able to titrate the correct desirable dose than if you just inject it or swallow it. So I think the smokability of fentanyl, the potency being high of fentanyl so you can smoke it, might actually be protective in a way. And then this relates to some of the things Cody was saying. I think COVID may not have been just COVID, but I think the confluence of COVID and fentanyl really put stress on the system. And I think a lot of high-risk individuals died. And it may be that if there was, let's say, 500,000 high-risk opioid users in America, if a bunch of them died in over 2 or 3 years during COVID, then when we come out of COVID, there are fewer of those high risk. The reservoir of high risk users is less because they all died. So it's just that I think the increases of 40% of mortality per year, like those sorts of things, may have just killed the existing. Excuse me for being blunt in how I say it. The existing high risk users. So now we are regressing to the mean. Social isolation, the reverse of the change of social isolation towards, and I'll give you specific data on the social isolation thing in a second. And then public education about fentanyl. The other thing I didn't include, I think the carceral system, people getting treatment in jail. Overdose deaths are fueled by cycles of incarceration. So fewer incarcerations, better MOUD in jail. That's probably a huge player here. Next slide. So if you look at total overdose deaths, this is over a 4-year period in Minnesota. And then you have the green line is opioid positive overdose deaths. This next pale line is bystander is present. And then the bottom line is naloxone was given. So you can see that a bystander is present that's about 75% of the opioid overdoses, but they only have naloxone less than half of the time. So both of these, from the green to the pale to the gray, all of those are huge variables about mortality. The more the bystanders are present, the less likely you are to die. And the more the bystanders have naloxone, the less likely you are to die. So you can see that those are both variables we could continue to try to optimize. And it's not like the majority of people who are present at the time of an overdose still don't have Narcan. So we are not there with Narcan. And so it probably helped a lot, but we have a long way to go with the presence of Narcan in the hand of the bystander when a person overdoses. Next slide. And this is the smoking versus injecting. These are trends, national trends about smoking versus injecting. Next slide, I'll show you state trends. 2022, if you look at smoking, is this by far, it's really pulled ahead of the pack, right? And injecting is now basically the least common route of using fentanyl in our community, whereas just in 2019, injecting was the most common route. So we got a true change in how people use fentanyl. I mean, there's still a lot of injecting happening, arguably more overall than 2019, but as a proportion of fentanyl users, it went from the most common route to the least common route.
Charlie, it'd be interesting to me how your clinic is. I had one injector the other day, and that's the first one I've seen for months.
Yeah.
I don't know how yours.
It's very noticeable that there's less injecting.
Yeah.
But we're still seeing it. I mean, we still see it routinely, but it is, we still ask, but it is the minority. I always ask because I'm thinking about Hep C and HIV risks and stuff like that, syringe programs. And we now mostly hear, no, we're not injecting, I'm smoking, I'm snorting, whatever. Next slide. The greatest number of Minnesota overdose deaths occur at home alone. Second place, where the most number of opioid overdose deaths are after release from which type of facility? So which type of facility is the commonest facility to be released from, and then you overdose and die? I know the answer to this, but I'm going to guess what I would have thought. Okay, you guys answered exactly the way I answered, and we were wrong. So y'all, this is to me shocking. This is shocking that the of overdose deaths in 2022, 1,000 of them, they're just at home alone, right? And then if you look at, they were just released from an institution, the leader, and it's like 8% of overdose deaths were just released from a hospital. That's more than jails. That's more than addiction treatment centers, whatever. Hospitals are the second leading circumstance after a hospital discharge. That is shocking and embarrassing. And because aren't we doing something about it? Like, who should be better equipped to set this person up for success than a hospital? And yet it's the second leading circumstance for a person to die. So
Charlie, do you have any sense whether that's ED or hospital inpatient?
I think it's both. Yeah. This is unintentional, but I think it's all drugs, but that's 85-90% opioids. And the suitors is the data at the bottom, so you can kind of scrutinize the details of this. So that's a call to action for people who are involved in hospital care, including, like you said, emergency care. I think what that means is very, very high risk people are going to the hospital with an overdose. So next, thank you for that. Thank you for the link. Next slide. Yeah. So yeah, and we're not doing it. So with the opioid epidemic, we are seeing improvements in Minnesota, which is like confetti falling from the season. But let's not get carried away because there's a lot more we need to do. Transitions out of hospital, naloxone access, MOUD access. I didn't even talk about that because last time I mentioned our MOUD rate is under 20%. So we're under 20% on MOUD. More than half the overdoses, no Narcan is present, even if a person's there. And transition out of the hospital is embarrassing. That said, people are smoking more than injecting, and naloxone and MOUD access, and probably some of the carceral justice changes have improved outcomes. Next slide. Okay, this is like hot topic. This is the first time I've done this, so I don't know timing, but I'm glad we're at least going to get through this. And then there's a speed round at the end. I am not like an expert in this, but I will summarize it the best way that I can, and then I want to hear your take on it. Portland, basically at the onset of COVID, around that time, changed drug law so that if you are using drugs, you are not incarcerated, but instead you are given a choice between getting an addiction assessment or paying a $100 fine. What they didn't plan on was the third option, which is ignore that and just keep using drugs in the public. And 95% of Portlanders who were given this choice, that a drug addiction assessment or a $100 fine, 95% said, neither. I'll just keep using drugs. What are you going to do about it? And the answer is basically nothing. Like, they continue to be able to use drugs. Death rate after this legal change went way up, like 30-40% per year. More on that in a second. So the death rate did get worse. And if you love Portland like me, and I've been going to Portland for decades, it's really sad to see what happened to downtown Portland. There is open injection of drugs. There is overdoses routinely just on the sidewalks. People, it is so obvious, open in your face. It is an open air drug using, drug dealing community. Businesses have had to close. People don't feel safe if they're not in that community. It's really sad. And basically, the people of Portland and generally of Oregon were like, Portland, an extremely liberal city, was 2/3 in favor of changing this law back. So like the Portland changed the law back this year, and now the law in Portland is much more like a traditional drug court system. So that it's like kind of a failed experiment, and yet statistically, it probably did lower the death rate. And those are statistical analysis of, yes, deaths went up, but deaths were going up everywhere, and fentanyl had just entered this community, and deaths would have been even worse if we hadn't legalized the way we did. So next slide. The question for you is, do you want those changes, similar changes to that? And I know yes, no is like a totally absurd way to frame this, but it was ugly in Portland, but it probably saved lives. Should we do that in Minnesota? Yeah, everybody says no, and I'm kind of a no as well. And just for reference, in case you're into this, I am going to put a really cool podcast by a national expert on drug policy. This is the Ezra Klein Show. Ezra Klein is very politically liberal. He doesn't bring politics into this particular podcast much, and the podcaster is super informed about these drug changes and the good and the bad. And it's just a really interesting podcast. He also has amazing comments about legalization of marijuana. So that's a fun podcast to listen to if you want to learn more about the Portland experience. And a question to you: how should we? Does anybody want to? You can unmute or you can put it in the chat. What should we be doing about our drug laws? And how can we improve our drug laws? Or if you want to talk about why you said no to doing what Portland did. Why do you not want to take on the Portland policy? Does anybody want to? I will share with you my answer on this, but why not be like Portland? Or what would we do instead?
Charlie, correct me if I'm wrong, but isn't Portugal's also you go two ways. You either go the legal route and have legal consequences, or you go to treatment.
Yeah.
And all drugs are legal there, but yet if you get caught with them and you're clearly having a problem, you have a choice.
Yep.
Is that a pretty good way of saying that?
Yep. Yeah. So that podcast also talks about the comparison with Portugal, and the podcast sort of like guest is really, really amazing in how he analyzes this. Portugal there was teeth to their policy, so you couldn't just ignore the choice, which is what happened in Portland. People just ignored those tickets. So Portugal did not let you ignore the choice. Also, Portugal has a very strong sense of community. Generations of your family have been living in your town. And so you are very tightly linked to your community, and you have a strong sense of, I'm not just Portuguese, I'm from Lisbon. I'm from a neighborhood in Lisbon. And so Portugal had this very strong sense of community. They made it they forced a choice. You couldn't just wave it off, but it did work in Portugal. An intervention like this did work, and they did more than just get an assessment. Like in Portland, it's like get an assessment. What's an assessment? Like, yeah, that's not really a treatment. It's just like you go through the motions of talking to an assessor. In Portugal, it was a more significant treatment. Portugal also has better access to MOUD than Portland. So Christine has a comment. Yeah, so I totally agree with Christine. She says, you guys can read this yourself, but when drug use is legal, it does seem to take over a city. The challenge, I agree with you. The challenge is it just visible? It's been there the whole time, and we just want to sweep those drug addicts under the rug, or is it, and it's just visible now? Or is it really more than just revealing what's already there? It's increasing in use or drawing people into the city. We'll talk about that.
So one thing I would add, like in a perfect world, I think like this could be a viable option. But the problem with Portland was it was all happening right as COVID was going down. So
Yeah.
everybody got pushed over to do that work.
Yeah.
And they couldn't get the money out. And then on top of that, they couldn't the type of people to fill the professions that would be the part two of that law, they weren't there. Like
Yeah.
that's the other problem
Yep.
is like that, for decades, if the response has always been, well, we'll let the police handle this and clean up all these societal messes, and you invest in that, it's like all of our other social services have sort of crumbled or been defunded or underfunded, however you want to phrase it.
Yeah.
So, I mean, you can't do part one without part two. And unfortunately, like COVID, and then just like the way the type of people you need to fulfill those roles for that second half of the actual response and services, we have a huge worker shortage in the US, and it's really hard to get people to fill those roles.
Yeah. Yeah. It coincided with COVID. It coincided with the sort of entry of fentanyl into that community. And housing is awful in Portland. And so there's also a housing shortage. There's like low income housing or housing for people who are unhoused is a challenge everywhere. But it took it was a really probably not a good place to be the first one to try this policy, given all of those challenges in general and specific to Portland. Tons of good comments. I'm not going to read them all, but there's like really good comments. Really good comments in the chat. Yeah. So, yeah. Okay. So next slide. I'll share some of my thoughts. I'm not an expert on this. This is just opinions. Food for thought. Housing and availability of treatment, especially including MOUD. This is exactly what Cody just said. Like, you can't do this in a vacuum. You need to have part two, which includes housing, it includes mental health treatment, it includes MOUD. A huge thing for me is primary prevention, which is stopping people from ever starting drugs or delaying the onset of drug use, preventing addictions, is in tension sometimes, not always, sometimes, with tertiary prevention, which is they already have an addiction. How do we keep them healthy? How do we respect their autonomy? How do we respect them as humans? They have an addiction. And I don't want to go on too much of a tirade on this, but what I see is sometimes people are all primary prevention. And they're basically like, once you have an addiction, you're a lost cause. Like, it's an incurable disease with, frankly, not the best outcomes. So all of our effort should be preventing it. So I'm not going to spend any time worrying about those unhoused, mental health, drug addiction, people on the street. That's not my problem. I'm going to spend all my energy and all my efforts preventing that. And then on the other hand, and just basically denying that we need to treat people with addiction with humanity. And then on the other hand, now increasingly you're hearing people on the opposite end of the spectrum saying, we're not going to stop drug use. Drug use happens no matter what we do. Like, we don't, like, you can't, nobody can ever stop an addiction from happening. Drug use is part of human nature. Some people even say it is a human right, a right to be able to use drugs. That is part of human nature. You can't stop it from happening. It's going to happen anyways. Don't waste your time on primary prevention. We need to be taking care of these people with addictions. Both of those, I don't have time for either of those people. Like, all primary or all tertiary. I think we always need to be thinking about harmonizing primary prevention, which does happen and can happen. Look at tobacco. Tobacco rates rise and fall over decades. We can prevent addictions. We don't harmonize that with taking care of people who have an addiction. And I think sometimes we don't those two groups are just kind of yelling at each other and not respecting the other group. But there was a lot of comments about concerns about families. So I also agree with those comments. I think we think about healthy people. I want to make this individual with an addiction, give them services and help them and not incarcerate them. Yes. But I also want the environment to be healthy, the community to be healthy, so that a healthy environment, and this may be controversial, a healthy environment is necessary to be a healthy human. And so let's not help people who are using drugs and in the process destroy an environment, destroy a community. And I think a lot of communities thought this. So very interesting thing that's happening in San Francisco. San Francisco doesn't want to incarcerate people using drugs, and particularly doesn't want to have racial disparities in incarceration. Super important. So there is a neighborhood in San Francisco called the Tenderloin. I would not recommend you walk through I've been through the Tenderloin. It's tough. I mean, it's tough in the Tenderloin. And the Tenderloin is basically an open air drug market. Drug use, drug sales, people that are really, really suffering because of drugs are openly visible in the Tenderloin. The Tenderloin is also a place where low socioeconomic and immigrants live in San Francisco, and there is a disproportionately high number of families, children of color, immigrant children. So San Francisco has this policy: we don't want to send the cops in to arrest the drug users in the Tenderloin. What that means is it's an open air drug market. And in those fancy, rich neighborhoods in San Francisco, if you want drugs, you drive to the Tenderloin. So the Tenderloin has become the drive-through service for anyone anywhere in San Francisco, and to go get their drugs. And there are families living in the Tenderloin trying to raise their families, and they have actually sued the city of San Francisco. These are low-income families, immigrant families, people of color, saying, because you are not enforcing the laws, we have an unsafe environment for our children. And if you are a child growing up in the Tenderloin, I mean, I can't imagine that it wouldn't be traumatizing. And I can't imagine that it wouldn't increase your risk of someday using drugs. So I'm not saying I have an easy answer, but I will say this is the bottom bullet point. Anything that, 2/3 of Portland wants to make a law more conservative. If you can make 2/3 of Portlanders vote to make a law more conservative, it's not a workable policy. And it's just the policy has to be acceptable, and the effects were so catastrophic appearing, even if it saved lives, that it's just not workable until there's a better system in place. So that's my tirade on that. Any other comments? Next slide. I'm going to see if I can get through a few methadone thoughts. Next slide. Okay, another choice. Pick one that you most agree with. Methadone programs, OTPs, should stay as they are. OTPs should remain, but they need major changes in how they provide care. We should do away with OTPs and instead let addiction clinicians, like let's say Kurt, gets a waiver and Kurt can prescribe methadone from pharmacies, or both B and C, both keep and reform OTPs and also allow for a methadone waiver so that addiction clinicians can prescribe from pharmacies. What would you vote for? And I will be done before 1:15. If I need to be done sooner, Kurt or Aaron, let me know. Okay, I love it. Look at this split. Yeah, so the answer that is happening is B, but D might happen. So next slide. So just as an overview, there are 2,000 OTPs in America, 650,000 patients. SAMHSA accredits it. DEA licensing is required. Think of it as directly observed therapy for opioid use disorder or a medical home for opioid use disorder. OTPs include medical, like hepatitis C screening, medical screening, counseling, vocational advice, assessments, and case management. Next slide. OTPs, we sometimes give them credit, but not methadone. We sometimes give methadone credit, but methadone in the OTP context. That's the only way we've ever tested methadone for opioid use disorder. Lowers mortality by greater than 50%. These days, we need doses higher than 120 for the fentanyl users. The retention is better than for buprenorphine. So retention rates are good, yet there is limited access. There are some new clinics in the metro area, but I don't know about greater Minnesota. And patients are often requesting methadone specifically instead of buprenorphine. Next slide. So there are concerns. People of color are overrepresented in OTPs compared to white people, or people of color are overrepresented in OTPs compared to what they are in the buprenorphine clinics. People of color end up in OTPs more commonly. Again, I'm not sure that's all a bad thing, but it is a disparity. OTPs are very focused on preventing diversion, preventing problems, punitive action, legalistic actions, punishments, restrictions. It's highly restrictive for people to get home doses, and so therefore it's not compatible. It can be compatible, but it's a challenge for work-life travel. Today I have a guy with life-limiting cancer, not curative, who wants to go visit a friend in California and can't because he's on a methadone program, or it's at least complicated for him. Nursing facilities, complicated. Patients sometimes call methadone programs liquid handcuffs, like methadone liquid is the medicine, liquid handcuffs. So that's how some of the patients feel about it. Next slide.
Hey, Charlie, can I interject for a second?
Yeah.
Methadone is really tricky in the carceral setting in rural Minnesota too, because man, if you don't have a local OTP or they're not, into giving take-home doses to the jail, that can get so sticky and present so many challenges. And it usually happens on Friday afternoon and you feel absolutely helpless. It's just
totally. And the DEA is considering changing their policy on that. And the SAMHSA, to the most that they could, which is hardly at all, tried to change that policy. But unless your jail has its own DEA license, you're still stuck. Yep. So, sorry, did you have something else?
Nope.
So methadone programs, when you enter a methadone program, if you behave well and have good drug screens, you get privileges. And if you have bad drug screens, we take your privileges away. In a way, a methadone program is a contingency management program. You get privileges for good behavior, you lose privileges for bad behavior. That's a contingency management program. It's not money, but it's privileges. So that's sort of interesting. Next slide. And then we're going to end soon, but at ASAM this year, there was a lot of talk about methadone programs are dehumanizing. All of these rules and regulations are dehumanizing of people, that we're treating them like criminals. We're treating them like they're a diversion risk. It's dehumanizing. Agree or disagree? So here's what I do. I come to Echo. I love coming to Echo, and I never finish my talk, so that Kurt and Aaron always invite me back. I always leave some slides on the table. It's like a cliffhanger. We're pretty split on the dehumanizing thing. I actually, in my OTP, I've been working in this OTP for 20 years, and it's hard to call something dehumanizing when patients are choosing it over buprenorphine and it lowers mortality rate greater than 50%, and the retention rate's better than buprenorphine. Maybe it's dehumanizing, but people are still getting better outcomes and are making a choice to enter that program. But I do hear that there are things that need reform. So there's federal reforms, and I'm going to cut to the chase, federal reforms loosen takeouts. It's the main thing. Next slide. State reforms. This is a bill that has not passed yet. Fingers crossed. Will harmonize with federal reforms, and we will have looser takeouts. Okay, the whole takeout program on our current OTPs is part of the contingency management aspect of the program. If you do well, you get benefits. If you do poorly, you lose benefits. We're going to take that away, and we're going to see how much methadone without that incentive program. I mean, Delta owns me because of I have a Sky Miles account and they own me. And this is even more powerful than that. So we're taking away an incentive program away from the methadone therapy clinics. We'll see what happens. So next slide. There is a movement to have waivers. We're not there yet, but the DEA has been made aware of this and they're considering it. So there may be a future where Kurt or me or any addiction clinicians can apply based on some criteria for a waiver and prescribe methadone to a commercial pharmacy. And that would be game changing for rural communities. Next slide. The question is, who should be eligible to get the waiver? And that's a big debate. Addictions certification on its own might not be enough. We might need some additional training. It's a debate happening right now. If it happens, who should have the right to just prescribe methadone to a pharmacy? And then next slide, I think I should stop. I think we talk about Aaron's point. We got to let jails do this better. It's a total mess in jails and nursing facilities. Next slide, I think, is the end. Yeah, so that's the end. I would love to sometime talk about the buprenorphine topic to hear what you all are doing, but hopefully that was really fun for me. Hopefully that was fun for you. I learned a lot from you and I appreciated being challenged.
That was awesome. I really liked hearing about other parts of the US and how they've addressed this and what's gone well and maybe what hasn't.
You know, I think that the whole buprenorphine, talk too I bet you that could last a whole hour, Charlie. I think really when we look at all the different ways to do things now, depending on whether it's your macroing or, how the patient shows up or, what you do with somebody overnight to get them back in. I mean, there's just so many things optimizing that treatment to think about. So
yeah, right now, I agree with you. Right now, in the buprenorphine world, we are looking at, not me, all of us addiction people are looking at every single step from you're using opioids to you're stable on buprenorphine and trying to optimize every single step. And there's just a bunch of question marks. And it's a really exciting time because I feel like it's like roll up your sleeves, all hands on deck. How can we optimize this? I think it's really exciting and there's a lot to talk about. I agree.
Do you want to plan for a month down the road?
Sure, we'll do it. I think Stacy had her hand up, but maybe she's not wanting to share anymore. Anyone else? This was so exciting to hear your take. Hopefully I provoked some thoughts.
Tons of thoughts. No, I thought that was great.
Mm-hmm.
Kind of makes your brain work.
So the stimulant use disorder link. Oh, awesome. Thank you, Will. Will is on it. A couple links Will has provided. Appreciate it. All right. Thanks everybody. Have a good Wednesday afternoon.
All right.
Thank you, Charlie. Thank you, everyone.
Yeah, bye-bye.
Yeah, that was fabulous, Charlie. Thanks for everybody coming. We will see you next week. And you just let us know if there's anything we can do to help. So have a good day.